Okay, so for this screencast, we're going to start to talk about how drugs work in the body, or pharmacokinetics and pharmacodynamics. So, how drugs move through the body, what drugs do to the body. So, here again, we start at the neuron and we look at different views of the neuron. Where drugs typically work is in the synapse. But what is a drug? In your discussion section, that was the thing I think the class had the most trouble with, is trying to define a drug. We can look at electron microscope images of a drug, and we could define them chemically, but I mean, what is the definition? A lot of you, when you think drug, you immediately go to illegal substances, and that was reflected in your postings. But what about drugs that are like medicines? Or what about vitamins? A lot of it was to treat illnesses, but what about like a poison or a toxin? If we use a definition of any substance that alters the physiology of the body, then food, nutrients, even water would have to be considered a drug. So again, here's some more electron microscope pictures of drugs. And what if we take this view? Any substance taken to get high or treat an illness. Well, what about caffeine then? Is caffeine a drug? Do you get high off caffeine? Well, maybe. I mean, I've heard people say a caffeine buzz. But there's lots of drugs that are taken not to get high or not to treat an illness. So it's really difficult to define a drug. Alright, now if we look at drugs and we look at like prescription drugs, you're going to have chemical names, generic names, and then trade and brand names. I'm typically going to stick to generic names or trade names. So this is Xanax. I bet you've heard of Xanax. So the trade or brand name here is Xanax. The generic name is alprazolam. And here is a chemical name: 8-chloral, 1-methyl, 6-phenyl, 4-HS, triazyl, 4,3-L, 1,4-benzodiazepine. Don't worry, you don't have to know that for the final. So a lot of people use tons and tons of prescription medications. If we look at antidepressants right now in the United States, the estimates are that about 10% of the population over the age 12 is on an antidepressant. These are huge numbers of prescription drugs that are being used. Some of them probably not in the way that they're prescribed. Anytime a drug is used not as prescribed, I think that starts to enter into the category of substance abuse. So here we see Zoloft. Nobody really abuses that. Percocet, they sure do. That's a painkiller. Xanax, Ritalin down here, Vicodin, Ambien, Valium. So you can see here some of these little things here. Why do people take these? Percocet, when it's time to relax. Xanax got passed over for the promotion. I'm not sure that that's exactly what those drugs were approved by the FDA for. Now this chart's a little old now, but here, this was a big deal. I wanted you to see this. If we look at the use of illicit drugs, I mean, we were looking at the Dawn data. You saw the numbers of deaths from illicit drugs, and you were quite shocked that prescription opiate medications were at the top of that list, but we really didn't even look at tobacco or alcohol. Or poor diet and exercise is a huge problem in the United States. So the deaths from alcohol alone overshadow all the deaths from illicit drug use. So I just want you to be aware of that. And then if you look at tobacco, it's unbelievable. So I mean, ridiculous number of people die every year because of tobacco-related illness. The single largest public health issue in substance abuse in the United States, after alcohol and tobacco, though, is prescription drug abuse. Okay, so when we talk about dosages, oftentimes they're in milligrams. A milligram is 1/1000th of a gram. If somebody says, oh, I'm taking 1 milligram or 0.5 milligrams of Xanax, what does that really mean? Does the dosage equal potency? Well, not really. So different dosages will reflect different levels of potency. Some drugs are very, very potent at a very, very low level. So we also need to take into account weight. So oftentimes drugs will be prescribed based on milligrams over kilograms. When you look at the dose response curve of a drug, what we usually see is an increase in response as there is an increase in dose. So sometimes there's a linear relationship where one step up in dose equals one step up in response, so it forms a nice straight line. But usually there's a curve, so at some point you get no effects, no effects, no effects, and then effects start, and then they'll kind of taper off a little bit. And then there's a threshold dose below which you're going to have no effect of the drug. Now here we have drug A and drug B. A is in the green, drug B is in the red. Here we see mortality over here. So not response. This is lethality. So here we're looking at percentage, and you would look at dose up until 50% of the subjects died in response to that dose. Now obviously we're not doing these studies in humans. This is work is done in animals. So if we look at an effective dose, which we call ED50, over the lethal dose, which is called LD50, like 50%, we can look at the therapeutic window of how drugs, the dose that's effective versus a dose that's lethal. And hopefully you have a huge window in that. If those two curves are very close to each other, that would mean it's very easy to overdose on the drug. So if we look at caffeine, a lethal dose of caffeine in rats is 192 milligrams per kilogram. So in humans, depending on weight, and some people are a little more sensitive to caffeine than others, that would be like 150 to 250 milligrams per kilogram of body mass, which would be like 80 to 100 cups of coffee taken within a really short period of time. That could be lethal. So then again, when we compare the effective dose to the lethal dose, we get the therapeutic index. So that's LD50 divided by ED50. So let's say the lethal dose is 10 milligrams, but the effective dose is 5 milligrams. So you would take 10 divided by 5, and the therapeutic index would be 2. 2 would be really, really low. You wouldn't want a therapeutic index of 2. So lots of you were commenting on how you thought that marijuana was so dangerous based on that data. I tried to explain that in the DAWN data, so many people use marijuana, they come into the emergency room for other reasons and might potentially die for other reasons, but they do have marijuana in their system. So the therapeutic index for marijuana, the ratio of the lethal dose to the therapeutic dose is about 40,000. So you'd have to get like a dump truck of marijuana and take that all at one time in order for that to be lethal. In contrast, if we look at something like Jack Daniels, alcohol, the range is between 4 and 10. And alcohol can be very, very lethal. So the therapeutic index for alcohol is pretty small. There have been no known cases of fatal marijuana overdose. So every drug that you take is going to have a primary effect versus side effects. You have to take into account side effects. Sometimes drugs are prescribed because of their side effects. Drugs oftentimes interact with each other. You can have drug antagonism. The drug antagonism would be a right shift for the effective dose. So one drug can inhibit the action of another drug, so you have to increase the dose. For a left shift, that would be called an additive effect, or even a supra-additive effect. Like we've been talking about alcohol and Xanax, taken together, alcohol and Xanax have an additive effect. So when we look at pharmacokinetics, or how drugs move through the body, I want you to remember this little thing right here. This is your key. ADME. Administration, distribution, metabolism, and excretion. So there's lots of different routes of administration. We call those parenteral routes of administration. SC would be subcutaneous, IM, intramuscular, IP, intraperitoneal, that's like in your gut, IV, intravenous. And there's lots of differences in the rates of absorption with different methods. So inhalation is really quite fast. A depot injection would be like a drug that's mixed with an oil that you can inject into a muscle that would slowly release over like a month. So when we talk about inhalation of gases, I mean, like that would be like huffing something or smoking something. What happens is the smoke or gas comes in through the mouth, through the trachea, into the lungs, all the way down to the alveoli. Here you can see the alveoli. The alveoli intersect with the capillary network, which forms like a spider web around the alveoli. And then you have the veins where CO2 leaves, and then the arteries where oxygen enters. And it's really diffusion across the cell membrane in the alveoli. But if you spread these alveoli out, it becomes like a huge surface area. There's other routes like intranasal or insufflation, like snorting drugs. PO is orally. Buccal is in the cheek. I'll bet you can think of a couple other routes of administration. Some of them, I mean, really anywhere in the body. So you could use eye drops. You could put something under your tongue, sublingual. Rectal. Through the skin, transdermal. There's lots of different ways. Okay, so when we look at a cell membrane, cell membranes have a phospholipid bilayer. And that bilayer kind of forms like a Ziploc bag around the cell. We've talked about the neurons already, so I want you to look at the first podcast to have a refresher on that. What we didn't talk about is lipid solubility. So what we really want is for our drugs to either cross the blood-brain barrier or somehow get into the bloodstream to affect a neuron. Now the way that drugs go through these phospholipid bilayers, they have to be very lipophilic. So what that means is that they love fat versus hydrophilic, like loving water. If drugs are lipophilic and they're really, really, really small, like physically small, they'll get into the brain. Once drugs are taken into the body, they're distributed throughout the entire body. Your liver and your kidneys are responsible for most of the metabolism. So the liver breaks down drugs, and the kidneys collect the waste material to be excreted into the bladder and the urine and then out your body. So drugs are metabolized. So we'll pick up with this metabolism in the next screencast here.